Our final panel will explore the outlook for healthcare policy as the 2020 presidential election campaign heats up. It's been nearly a decade since the passage of the Affordable Care Act. Here to help us digest what's on the horizon is Senator Tom Daschle, founder and CEO of the Daschle Group and former Senate Majority Leader. At the Daschle Group, he leads a strategic advisory firm that advises clients on an array of economic and policy issues. He served in both the House of the Representatives and the Senate as Senate Democratic Majority Leader. He steered the Senate through historic economic and national security challenges. Senator Daschle is a well-known expert on health policy reform and has written 2 books on the topic. He is a founder of the Bipartisan Policy Center, an organization dedicated to finding common ground on some of the pressing public policy challenges of our time. Welcome, Senator Tom Daschle. Next, we have Molly Smith, Vice President of Coverage and Estate Issues Forum at the American Hospital Association. In that role, she leads the association's policy work, covering areas such as high drug prices, surprise billing, and price transparency, with the goal of supporting patient access to high-quality, affordable health care. Additionally, Smith manages the State Issues Forum, which brings together state and regional hospital association executives to share information on policy. Previously, she held positions at Manut Health as a policy and business strategy consultant, and at the Centers for Medicare and Medicaid Services, where she specialized in Medicare payment, Medicaid eligibility, and health information technology policies. Welcome, Molly Smith. And joining us to moderate the discussion is our very own U.S. News political editor, Morgan Felchner. Welcome, Morgan.
Hi, everybody. Thanks so much for joining us today. I think we're going to have a great conversation. First of all, I'm thrilled to be talking about healthcare today rather than impeachment, because it's really been, the focus of my life for the last couple of weeks, months, I don't know, however long it's been. But I want to kind of kick off to learn a little bit more about the Bipartisan Policy Center and what ideas are coming out, what ideas that you guys are working on in a path forward to healthcare reform. Senator Daschle.
Well, Morgan, we're really focused on 5 primary areas right now, ones that your audience are certainly will recognize. The first is rural health. There was a real powerful piece today in the Washington Post about the state of rural health and the reliance that people have on telemedicine and telehealth especially. But we're focused on how we can deal with the provider shortage that we face all through rural America today and the pressure that rural hospitals especially are feeling. So that's one area. The second is long-term care. With the explosion of the baby boomer population at this stage in life, it is critical we begin to find solutions to how we address the challenge of long-term care. That's another area that the VPC has been focused on now for some time. We'd like to improve Medicare and Medicaid in a number of ways and migrate off of fee-for-service, as your previous speaker was addressing, and that's a big issue as well. I think it's important that we improve the individual marketplace, and we've been working on a number of different solutions on strengthening the individual market today. And then finally, as with everyone else, we're focused on drug prices and trying to find ways to address drug prices going forward.
Great. And Molly, to start with you, I wanted to ask about state-level actions that are happening around the country. Are there things that are working in certain parts of the country that we should be modeling across the country?
Yeah, absolutely. And I'll take this question sort of from 2 perspectives or 2 sort of areas within the healthcare system, one being coverage, the other being the sort of broader delivery system reform. And I think what we've seen play out in the states is, I think what we all know at the federal level but have struggled to achieve is that universal coverage is possible. There are a constellation of policies that we can pursue, everything from some states have put in state-level mandates. A critical piece is states adding subsidies on top of what the federal government makes available to make those available to more people. Trying to shore up the marketplaces, as the senator just mentioned. putting reinsurance programs in place to really drive down the cost of coverage to attract people. There are things like that, and several states have achieved universal coverage. So I think that those are great places to look for the federal government. In terms of the broader delivery system reform, again, there are a number of states that are real leaders here. I mean, when you have the lever of the Medicaid program, of your state employee benefits program, you obviously have a lot of purchasing power, obviously also as a regulator. And so I would just point to a couple of examples. I think right now North Carolina is really the state to sort of watch. They have a lot of activity going on that sort of spans the gamut of healthcare issues, but they're really working both through their Medicaid program, state employees, but also with their private payer, their largest private payer, largely working in tandem with them to really focus on care coordination and doubling down on primary care and making sure that people are not falling through the cracks, that there's the data infrastructure to share information across providers. So that's just one example that I'd look to right now. It's very much happening in real time, so I think the outcomes of that we'll be looking at for years to come, but a lot of the work is going on right now.
Sure, and I think either one of you could probably take this, and hopefully we can hear from both of you, but what types of policy actions by providers, by government, by insurers that are necessary right now? What are the things that we should be doing in this country?
Well, I'll start with your last item. I would like to see pharmaceutical companies drop their drug prices. That would be a big step towards affordability. I do think there's a lot of work for all pieces of the healthcare system to sort of align incentives and also to address one issue that I think is really frustrating for a lot of our members, which is just the administrative waste and rigmarole that occurs in our system. A recent study showed in the $200+ billion what they think wasted per year in just variation in dealing with different types of, whether it's claims or prior auth or all the kinds of things that you have that really you could maintain a private structure, a private coverage structure, and still standardize a lot of those things and get towards a more affordable healthcare system.
Mm-hmm. I would say that our whole fee-for-service mechanism generates, I think, a greater degree of inflationary pressures. I mean, we've looked at ways with which to address that whole fee-for-service accelerated notion of pricing, and I think gradually we're going to be moving away from that and look at more global and experiential approaches to good payment. But I think that's a big part of it. I think Molly put her finger on another area, and that's the administrative waste we see. I think there's excessive use of technology sometimes. We don't put enough. We have a sickness system, not a wellness system. We have to put a lot more emphasis on prevention, on wellness. I think it's important as well that we recognize that there are societal issues, nutrition and education and a lot of other factors that really play a role as well. So the whole socialized approach to medicine needs to be examined more carefully, and we need to do a lot more in that regard.
Yeah. Could I just actually follow up on this last point that he made? And I know that our last speaker talked about this a lot, but that we know that we've got a serious problem with the health of our general population, and there's a lot that we need to do to improve the health and well-being of our citizenry. But and we see a lot of that manifest at the doors of the healthcare system, and yet so much of what's driving that have really very little to do with the healthcare system. And the healthcare system has currently very few levers to really sort of tackle those issues, whether it's housing instability or food insecurity and lack of transportation. And I think where we're at right now is, I'm really glad to see that there seems to now be universal recognition that those are a lot of the factors that are driving poor health. But where I think we're really struggling right now is whose responsibility is it? What are the right interventions? Whose responsibility is it? How are we going to pay for those? And I do worry a little bit about that right now. We're seeing a lot being looked at to the healthcare system to sort of say, you know what, at the end of the day, it's manifesting at your door, so you need to do something about this. And I don't see in all communities that we see a really clear sort of systematic approach where there is, we're understanding what a community needs, someone is convening and organizing, we're ensuring equity and access to these services. Because I think how it's playing out now is that if you happen to be in a community with, health systems and payers who have the resources and are invested and committed in a state, that's great. And if you're not, you might be left out. So this is just an area that I think we're still really figuring out. And is very crucial, but we haven't gotten there yet.
I think Molly puts her finger on a really important point, and that is that we can't rely simply on the infrastructure we have within our health system to address the broad array of challenges we face in healthcare today. It takes a community, it takes the employers, it takes the schools, it takes just about every segment, the family itself, taking responsibility. But we all have a role to play, and I think we've got to put more emphasis on that role. We can do part of that through public policy, but a lot of it has to rely on the initiatives taken by states and communities and families themselves.
You're getting to the social determinants of health here, and one of the things that I think is interesting is when we hear about healthcare, we hear so much about insurance. We don't hear about all the other parts of healthcare, and we don't hear about the social determinants and what people are learning and not learning about how to stay healthy. So the healthcare system is a lot broader than just insurance. Are there things that, we have a room full of hospital executives here, are there things that hospitals can do in addition to some public policy and things like that can improve this issue?
Yeah, absolutely. I mean, but let me just, one thing I will say though is that I think it is appropriate though that we do focus on the importance of coverage, because I don't know how you as a society intervene early or pay for these services that you need in order to, public health interventions. If you don't have a regular source of contact with your population and you don't have them in a regular pattern of, going to the doctor or, getting their vaccinations, coverage really is critical in order to make that happen. I mean, yes, there may be some workarounds, but they're workarounds. And so I would just say that I think there's an appropriate level of focus on making sure that everybody has a source of coverage. That being said, once you have that coverage, what do you do next? And I think this is, again, what we're still figuring out. I mean, we know housing is probably one of the best investments that we can make to deal with a very high cost population of the homeless. We actually do have hospitals and health systems who have invested and are building housing. Now, can every hospital and health system do that? Absolutely not. But something that every hospital and health system can probably do is screening, is actually starting that conversation with their patients. Now, housing is going to be a more obvious one, but there are lots of other questions that we can begin to ask to start to figure out what's happening in people's lives, and then make sure that we can connect them to the right resources, whether it's hospitals providing it directly or sending them, connecting them to someone else.
I would drill down on a couple of things Molly said. First of all, when it comes to coverage, I agree completely that coverage is essential. We don't have universal coverage in the United States as much as we'd like to think we do. We have at least 30 million people who don't have any insurance for all kinds of reasons. But we have another 60 to 70 million people who are underinsured, who don't have coverage providing the kind of benefits they need when they really need them. And what's really stunning is a majority of the American people in poll after poll have noted that they couldn't afford a $400 surprise bill of any kind, medical or otherwise. And so you've got a lot of financial fragility built into our healthcare financial system today around coverage that really has to be addressed. And the other thing that I think we're becoming more cognizant of is the ability to provide care in non-traditional settings, and homes in particular. I think there's more and more of an opportunity with technology and with services provided, and many hospitals are helping lead the way to do just that.
Now, we can move now, I think, to the hot topic, Medicare for all. Elizabeth Warren recently released her Pay For plan, and then later her transition plan. It's obviously not going to happen in this Congress, and I think even the political viability down the line is questionable, even if a Democrat takes the Oval Office. But how far are we from a single payer system? Can that happen in the United States?
I don't think it can happen anytime in the foreseeable future. We've had a debate about the role of government in healthcare for over a century now, since Teddy Roosevelt's time at least. And over that time, we've migrated from almost an entirely private system to one which is now about half and half. I call it a $3 trillion public-private partnership. Democrats would like to move the needle more towards a government role, following our OECD countries and Canada and other countries that seem to have done it reasonably successfully. But there are many who believe that there has to be a role for the private sector as well. I don't think we're going to ever come to a consensus completely. There will always be this question. The ACA was the latest installment in this public-private partnership. My guess is you're going to see a continued role. I think there is a possibility of a Medicare option, especially if it's Part C. I think there's a lot of support for Part C. It seems to be growing in popularity at about 35% enrollment now. So that's one possibility, but I don't see Medicare for all being a political reality anytime in the near future.
Yeah, I mean, I completely agree. And I think that it's frustrating because there's so much that we could be doing today to fix our current healthcare system and really build on what I think is, I mean, it's an incredible achievement that we have about 90% of people covered. There are very clear things that we could do on the policy front to close the remaining coverage gaps and still retain what really works. Choice, innovation, a lot of these things that we are able to do or enjoy sort of at a greater level in this country because of our public-private partnership. And, our perspective is we should definitely retain that and retain what works and then try to do the things that we need to do to close the gaps.
So what can we do to close the gaps? Is it a more moderate approach like Pete Buttigieg's Medicare for all who want it sort of thing? Is that a path forward, or what are the steps we can take?
Yeah, so this concept of a public option I think is really appealing to a lot of people because the idea is that you can sell something on the marketplaces that is cheaper than what is currently available because the government will be able to negotiate lower prices for the care, the care that's part of that package. I will say that we're very concerned about those types of approaches, particularly to the extent that they crowd out or attract people away from commercial coverage, because right now the way most of them are modeled on a Medicare rate. And Medicare does not pay the cost of delivering care. So if you are increasingly moving more of the population into a product that is underpaying the healthcare system, we're very concerned about how that might exacerbate access to care, the financial viability of rural hospitals. We've had more rural hospitals close this year, or the pace is the fastest that it's been in recent years. So we have real concerns about taking that funding out of the healthcare system.
One of the opportunities that we really haven't pursued effectively is how do you build on what we did with the ACA. If we would have kept the reinsurance program, if we would have increased the subsidy for those over 400% of poverty, if we would have looked at ways with which to ensure that public-private partnership could be robustly maintained and supported, my guess is we'd do a lot better. I actually believe the mandate worked as well, and I think that would have been helpful. But we've got to look at how we address young adults and young people especially, and bring them into the marketplace to make sure the actuarial balance is what it needs to be. But those things can be done, and there has been shown to be bipartisan support for many of those initiatives, and I hope we can continue, regardless of what else happens, focus on the things we know work and we know have some support on both sides of the aisle.
Sure. You mentioned, Molly, briefly the Medicare pricing, and that brought to mind for me the Trump rule from Friday about price transparency. I just want to dive into that a little bit more. Price transparency in the word sounds great, but can you talk a little bit about it from the perspective of the American Hospital Association and the issues that you see with the rule that was issued on Friday?
Yeah, absolutely. So we recognize that, and we fully support increased transparency for patients about the information that they need to make their healthcare decisions. And obviously, patients both need and want more information about their cost exposure. I mean, I think that the high deductible health plan is a perfect example and cause to a large extent for why that's true. That being said, what we hear from many of you, our members, is that patients are frequently asking for information about the cost of their care, but what they really want to know is what is it going to cost them? What can they expect to have to pay? And the rules that the government has put out, which were final for hospitals but proposed for insurers, do not do that. In fact, what they're really focused on in those regulations is disclosing the negotiated rates, the proprietary rates between providers and insurers. And from our perspective, that's extremely risky government, sort of overstep into private contracting. And the reason is that there's a reason that these rates are kept private, as they are in many other markets, and that has to do with, the risk of collusion, the risk of already consolidated insurance markets sort of driving down rates again to an unsustainable level. So it's unclear what a patient would do with that information. So what we've really been focused on and what we've been trying to work with the government on is how do you get better access to that out-of-pocket cost information, which I know also sounds like it should be easy. It's not, and it takes a lot of work, and I think the government has very much underestimated the real challenges that exist in being able to give patients estimates about their care. But that is really what we think we need to be working towards, is their out-of-pocket exposure.
I have little to add to that. I think it is important we continue to strive for greater transparency. The healthcare sector is by far the least transparent of any sector in society today. It's the only sector of the economy where at the time of purchase we don't know what it's going to cost or who's going to pay. And we can do a better job. We've got to find a way that accommodates the concerns that Molly raised, but we can't let go of the need to find ways with which to ensure that the customer, the consumer, the patient has more information.
Could I just one other comment about this that I think is a little challenging, is that on one hand, we are, as a healthcare system, trying to drive towards more coordination. You know, doctors and other clinicians talking with hospitals and other facilities, sharing data about patients, being able to intervene early, tracking them across their course of care. Are they filling their prescriptions? If not, are you following up? All of that. And yet, rules like this price transparency rule are really geared towards, like, how can we drive patients just to the lowest cost provider? And what we find happening in a lot of communities is, as that pressure gets put on, there's not a recognition of how that can disaggregate that care coordination that we're all working towards. So as we're thinking about increased transparency, which again, we completely understand, we need to make sure that we're doing it in a way that still keeps patients within a system of care that is, you know, again, talking to each other, that is coordinated, and that we're not just biting off little pieces here and there and saying, we'll go over there, oh, that organization can't share your lab results with your doctor's office or the place where you're ultimately going to get, let's say, your surgery. We need to be very careful about those types of things.
And this was a new regulation. Are there any other regulatory things that we can expect over the next year? Is there anything else coming down the pike?
Yeah, I mean, it's been an incredibly active administration, and even though things do tend to slow down a little bit in election year, we have every reason to believe that things will continue. Sort of on the positive front, we as a field have been asking for decades for changes to the rules around Stark and anti-kickback. These are rules that, you know, were understandably put in place to try to protect patients from some nefarious financial schemes, but what they have ended up doing in practice is really prevented you know, hospitals and doctors and other clinicians from working together, especially in value-based payment arrangements. The administration, now, while we would like to see further legislative action on that, the administration has put out proposed rules that we think go quite far and are in a very positive step towards alleviating some of the both uncertainty as well as the restrictions that, you know, where they were able to make change. So I think that's one real positive. I think we do need to be very careful back on the coverage side about some of the actions that we've both already seen and that are possible down the line. So just this morning, we did see that there was the administration has been working on, in the Medicaid space, some guidance around block grants within Medicaid, something that we've long been very concerned about. And, you know, we've known that they've been very interested in pursuing additional block grant guidance in the context of waivers in the Medicaid program, and that there was some guidance pending under review. We saw this morning that it was withdrawn. Now, we don't know if that means it's withdrawn forever, if that just means it's withdrawn for a period of time until they figure that out, but things like that we'll keep our eye on, because we are concerned that they could end up resulting in an erosion of coverage.
Okay. And, you know, we've addressed regulatory. What about legislative? Are there any things that we can see over the next year or so in Congress in terms of healthcare? You
know, Morgan, this is a very, very transformational time, and I think we're going to see healthcare policy and healthcare transition occur on 5 levels, not just the one. And I think the executive branch, of course, with all of its regulatory authority, is going to be one of the dominant players as we see this transformation take place. And that will lead then to things that are going to happen in the states. They've been very proactive in giving states more of a role and more autonomy in their waiver system, 1332, 1550. So I think you can expect to see a lot more activity at the state level than we have seen in many years, in part because of the greater autonomy that they have. The third area that people don't fully recognize sometimes are the courts. The courts are going to be very active in the next year or so with a lot of decisions affecting health, and that's going to play out. And then, of course, the Congress. And unfortunately, I wish I could say that the Congress is going to be more productive. I don't see Unfortunately, it's as dysfunctional and polarized as I've ever seen it, as I think we've ever seen in history, frankly, lamentably. I don't see any real possibility, but you could be surprised. I mean, there are potential for many areas of bipartisan compromise: surprise billing, drug prices. There's broad support for community health centers and the reauthorization of community health centers. In fact, it's essential that we provide some kind of a extension of that. So there are opportunities, but right now there really isn't anything that I see in the next couple of months that will generate the kind of bipartisan support necessary to be enacted.
Yeah, I would just echo that. I think all of that's right. Nothing comprehensive. And it is kind of surprising that we haven't even been able to get through some of the issues that you mentioned, like surprise billing, where there is just such broad consensus that something needs to be done. I mean, it's clearly the problem is what exactly that solution is, but you would think with the amount of will that we would be able to achieve that, but we're still working on it.
Sure. I think we only have time for just one more question. So my last sort of wonder here is there any examples from overseas that you think are instructive for the United States? Should we be copying what someone else is doing?
Interestingly, Taiwan did just that in the early 1990s. I'm sure some of the audience know the story, but they went around the world and took the best features of each one of the countries they visited and adopted it, and they have one of the best healthcare systems in the world today. I don't think we can. There's no one single system that we can adopt, but there are lessons to be learned from other countries, good and bad. And I think we ought to continue to do that. There are some great books that have been written about that, good reporting that have indicated, that there are ways that we can improve. The previous speaker addressed our current standing in the world when it comes to healthcare statistics, and it's not pretty, and it's something we have to address. So I think there are lessons to be learned and things to be addressed that are addressed successfully in other countries. But I think we've got this public-private partnership that is no system, it's a collage of subsystems, but we can make it stronger and better, more accessible, less costly, and we need to do that.
Yeah, and I would just add that, I think that we get really caught up in the comparisons or the concerns about models like Canada or New England or England, UK, or France. But really, there are other countries that have maintained a public-private partnership, or honestly have largely moved to a private administration of their healthcare systems, like Germany and Switzerland, but that do so with a hefty dose of regulation on top to make sure that people don't fall through the cracks, to make sure there's equitable access, that what happens when people leave employment, that there's a stopgap there. But I think those two countries in particular are definitely a place for us to look, because they do rely on private insurers. Again, it is set up very differently from our model today, but when we talk about achieving universal coverage, I think we all now know that and single payer are not synonymous. And from our perspective, they're definitely not. We are fully supportive of universal coverage and working towards it, but not a single payer model. And yes, we do look to those other countries to see what's worked well.
All right, I think we're out of time, but does anyone have any last thoughts you want to get in before we go?
I just think it's important to be engaged. I think we've got to be resilient, we have to be innovative, we have to collaborate, and we have to be engaged in the process. This isn't a spectator moment. This is a time to be engaged and to voice our concerns and our interests and our ideas with our members of Congress and others. And so I would just urge engagement.
Great. Well,
Thank you.
I want to thank you both for coming. Thank you so much for joining us. It was a great discussion.